got long-term biologic fixation, improves TKR longevity, and in the event of a revision, there is easier revision with less bone loss. But there are certain very significant problems. There is a lack of tibial ingrowth because of seesaw effect, and usually the femur can integrate, but the tibia does not. Further complications, of course, are there, and there is a lot of screw track osteolysis because the screws are used to initially fix the prosthesis onto the tibia. Polythene, there are thinner inserts and they are non-conforming. So coming to the question of constraint, the goal is to use the least constraint design that will provide a satisfactory result. And if we go from a CR knee to a hinge knee, we are actually going to increase constraint. Most of us do this. The artificial components inserted into the knee are not linked to one another and rely exclusively on soft tissue tension. But there are trade-offs in TKA design geometry. For highly conforming implants, there is a large contact area with low contact stress. This prevents translation but transmits shear stress to the fixation interface, leading to implant loosening. For non-conforming implants, the contact area is small, so there is per unit high contact stress, leads to polyethylene wear, osteolysis, and again implant loosening. As is usual in two contradictory situations, we managed to come out with a compromise. Mobile bearing TKA, high conformity with good fit allows translation, low interface stress, but there are concerns here too, like for example, backside wear and spinouts. So differences between condylar and mobile TKR, tibial component is topped with a flat metal piece in a condylar TKR. Here the insert can rotate. There is only gliding motion in a condylar TKR, but gliding and rotation both are present in a mobile TKR. Whether to retain the cruciates or not. I think your computer is running out of power. CR knees have less conformity, allow natural femoral rollback, and require good ligament balancing and allow proprioception. PS knees, on the other hand, have more reliable stability with predictable kinematics, and they do away with PSL altogether. But they are more constrained, the potential for wear on the tibial spine is there, and possible dislocation. So PCL retention or PCL substitution. But if you do retain PCL, there is better range of motion, more symmetrical gait. This is not proven in case control studies. Less femoral bone resection is required. PCL needs to be accurately balanced, and it is questionable for very deformed knees, which we normally get. PCL substituting prosthesis, there is an easier surgical procedure. Seesaw effect is prevented. There is lower tibial polythene contact stress. Posterior tibial component displacement is possible, and older designs had a Petlock-Lung syndrome, which is not present now. When do we use a constrained knee? Used when a knee is highly unstable and a patient's ligaments will not be able to support any other type of knee replacement, especially severely damaged knees, or knees in which you have to sacrifice the medial collateral. Two pieces are connected with the hinge-like device, which I think you all know. Special knees like unicondylar knee replacement, indications are very limited. Younger patients with unicompartmental disease instead of an HTO, and elderly thin patient with unicompartmental disease. Both of them we don't get much in this country. Contraindications if they've got a flexion deformity more than 5 degrees, a range of motion less than 90, and angular deformity of 15 degrees. And of course, other compartment disease. Bi-compartment knee replacements are also there, which replace the medial side as well as the patellofemoral side. So these are custom made usually, and I have no experience with these knees at all. Medial pivot knees have recently come in vogue, and this presupposes that the medial condyle will act like a ball, the femoral condyle, and the medial tibial side will be a socket, and which will naturally reproduce the motion of the knee with optimized range of motion. Companies have brought out gender-specific knees on the premise that the female knee is different from the male knee, and provides this gender-specific process provides surgeon with ease to insert the femoral component and may alleviate short and long term. This is also not being proven yet. The system which you use should also allow you intraoperative flexibility, an extensive range of femoral and tibial components with compatibility, stem extensions, and tibial wedges and augments. Why do you use tibial wedges and augments instead of bone graft? They are predictable early results, satisfactory load transfer, intraoperative flexibility with elimination of the risk of disease transmission, malunion, non-union, and resorption. And of course, they increase the strength of the construct. And these are some of the wedges available. And these are some cases in which half wedges are used, a full block has been used here and has been neutralized with the stem. And of course, this patient with the very badly deformed knee, the fracture on the femoral side, again a wedge on the tibial side as well as a stem on the femoral side to fix the fracture also. Trabecular metal wedges and femoral tibial cone augments. I think there is a lecture later on in this hall regarding these, so I'm not going to speak much about them. And finally, the final hinge, which you can use for special situations like, for example, tumors, in which you have to remove the whole of the distal femur and replace it with a large megaprosthesis. So successful result depends upon careful planning. You must be able to anticipate problems, good surgical technique, a sound implant design with appropriate material, a system with good intraoperative flexibility, and patient compliance with rehabilitation. Thank you.
Thank you, Professor Rastogi. Very nice talk. I would like to ask the host, would you like to ask him questions now, or do we leave it for panel discussion later on? Because I know certain number of speakers would like to leave as soon as they're present here. So we'd like to we have time. Do you want to ask him a few questions now? Instead of leaving a panel discussion, what would you like to do? Okay, that's grand. Okay, thank you. We could continue with the next one. Is Sanjeev here? Dr. Maria? SKS Maria? He was the second speaker. Is Dr. Maria around, please? Okay, I think we'll continue with the next speaker. There is, we have soft tissue balancing and revision TKR, Amrit Goyal. Is Amrit Goyal around? Thank you. Right. So Dr. Goyal, you again allocated 15 minutes.
Good morning, everybody. My topic is soft tissue balancing and revision total knee replacement. So we are all well aware of the principles of TKR surgery: restore alignment, joint lines, stability, and range of motion, patellofemoral kinetics, and appropriate fixation techniques. In fact, any case of revision consists of 5 steps. First is exposure, where you have to have the quadriceps snips or tibial tubercle osteotomy if required. Second requires an implant removal with minimum amount of bony resection. Third is the bony preparation to accept the implant. The fourth is a soft tissue balancing, and the last is the final implant fixation. So any lecture without the bony preparation is incomplete, but I'll stick to my topic. So preoperative planning, as we already know, is very essential, and you need to have all the necessary instruments, implants, grafts, whatever you require beforehand. Implant options we have already discussed with Dr. Rastogi, the PS to the hinge knee. These are the various implant options you have, the TC3 design which might be required. And for the exposure, you can have to assess the integrity of the collateral ligament, patella ligament. Patella exposure might be very difficult in severely fibrosed knee, and you might need a quadriceps VY-plasty, snip, or an osteotomy for this exposure. So quadriceps snip is basically you extend it laterally. VY-plasty, many people are shying away because of the extensive devascularization required. Tibial tubercular osteotomy gives you very wide exposure, but the problem is with the refixation. And the key is to have a very long flap and leave the lateral part of the sleeve intact. It might be a good option in case of a cemented revision where you might need to remove the stem. A brief classification of the defects. A type 1 is basically just like a primary knee with healthy cancellous bones and no defects. Type 2 has cancellous defects and metaphyses might be empty, but the ligaments and the condyles are still intact. Type 3 is a difficult problem with the condyles might be off, there might be severe cortical defects. And after every exposure and removal of the implant, the femur might look like this with a gross osteolysis. So a small bony defect classification. If it is a small defect, it can be filled with a cement, and larger might need metal augments and bulk allografts. So we need to restore the mechanical axis. We generally use the intramedullary instrumentation. I feel is better for the revision knee because many of the landmarks are absent. We routinely use it for the femur in the primary, and for the tibia also it can be used in the. So just for the augments, these required in the soft tissue balancing. If you put the posterior distal augments, and these are required to restore the joint line, and for the posterior augments, they decrease the flexion gap, and a selective use of these posterior femoral augments can even control the rotation of the femoral component in case of severe bone loss. You can use a larger lateral femoral condyle augment than the medial side to correct the external rotation. Stems may be required, and they may be in poor quality of bone. They may be straight stems or offset stems. Offset stems have the advantage of giving a good bony coverage even in case the canal is not in line with the intermedullary guide. And you have all the fancy hardware. You can use the cones, sleeves, but these are very costly things. So let's come to the flexion extension gap. And what we need is a ligamentous, the balance must be corrected. And more or less, the principles are the same as any primary knee replacement. And whatever gap is loose, extension or flexion, you have to move the component size up or down or change the position and correct the ligament balance. So if we do not correctly balance our revision knee, we might need a constrained implant. And as Dr. Rastogi earlier pointed out, the more the constraint, the less the survival. So our goal is to provide the least constraining processes with a good amount of soft tissue balancing. These are the steps. First of all, we need to go stepwise to have proper ligamenting balancing at the end. The first step for any revision setting is to recreate the femur. After the femur has been recreated, you can build the flexion space, then the extension space, and then if either space is mismatching, you can adjust it by using the flexion extension algorithm. And recreating femur requires two things. It affects either flexion or extension. First of all, you need to size the femur correctly. You can use the other side of femur, you can use the component size removed. Many a time there is tendency to put a smaller size of the femoral component because there is bone loss and we feel happy that we don't need any augments. But we have to, if the use distal bony, sometimes we need distal bony augments to build up the femur and posterior augments to build up the flexion space. The problem is that many of these anatomical landmarks which you normally use are missing. The femoral condyles might be deficient, and one axis which we can use is the transepicondylar axis, which is there. AP axis is also difficult to determine because white slide line may be difficult to draw. So I recommend that you use three landmarks. First of all, transepicondylar axis. I think this has gone off. Can anybody connect the power charger?
Sorry, is the computer's gone off?
Yeah, the power is off. Oh. Excuse me, can you connect the power to this computer? There's no charger.
In the meantime, I'll just keep going. Dr. Goyal, I'm sorry I got a bit distracted when you were starting off. Which hospital are you in? Are you working in?
I am working at SN Medical College, Agra.
SN Medical Agra. Okay, that's grand. Okay. Yeah, interesting that you talked about, while we'll keep the session going in a way, that you talked about the transepicondylar and the Leo-Whiteside's line, all that. Is there anything else that you always look around before that? Because certain implants don't. I'm an LCS user. It doesn't give you the rotation. It doesn't let
what
you.
What I normally use is, once we have made the tibia, we can use the flexion gap method to find the exact rotation of the femur on the AP as well as the flexion as the extension thing.
You could continue now, please. Thanks.
Thank you, sir. So transepicondylar axis is one thing which I rely upon most of the time. And second is I can use the flexion gap method to get my extension and the flexion gaps right. just like a primary femur, you can have the transepicondylar axis, and you can have the femur parallel to the tibial cut after you rebuild the tibia. This is the parallel gap method that I was talking about. So we have to restore the joint line. It has been shown that around 8 mm in the posterior stabilized and 3 mm in the CR knee. If we go more than this, then there is problems with the patellofemoral joint. The joint line can be seen that it is 2.5 centimeter from the lateral epicondyle, 3 centimeter from the medial epicondyle, a centimeter from the patella, and 2 centimeter above the fibula. So these are your anatomical landmarks. And elevation greater than 8 mm had problems. Now the thing is to rebuild the flexion space, and I generally use it, make it perpendicular to transtibial axis and try to cover the entire tibia. So balance the flexion space, and with the flexion gap method, you can use the poly to get the rotation right. If the rotation is not right, then you will have asymmetric ligament balancing and problems later on. So after you prepare the tibia, you can use the spacer to get your orientation right and rebuild the femur on that. And rebuilding the extension space, I would say, is easier, because you just need to put the distal femoral augments to bring it to the joint line and use the anatomical landmarks that we referred to earlier. And after you have rebuilt the flexion and the extension space, then you just need to fine tune the ligament. You can use a flexion extension algorithm, which if you just go step by step is very easy. So if you look at the algorithm, this is the extension which can be either tight, okay, or loose. And for the same for the flexion. So if it is in the number 5, you are perfect, you don't need to do anything. And then if both the flexion and the extension gap are tight, so what would you like to do? It's simple. Use a thinner polyethylene. Or if you are worried that your joint line might be going up, you can just resect more tibia, and then both the flexion and extension will be balanced. So this is a problem here. And for the algorithm number 2, with the extension is fine. So you think the joint line is the right level, and the flexion is it is okay and tight. So what we can do is a tight flexion means you can downsize the femoral component, or you have to move the offset stem to push the femoral component a little anteriorly. So use an offset stem to move the femoral component anteriorly, or use a smaller femoral component that might give you more space on the flexion side. And you can also use the distal femoral augment to move the whole of the femur a little down, and then use the thinner polyethylene. So balancing after we rebuild the femur and the tibia is easy, and you just need to apply these 3 principles in most of the cases. Now the opposite case, it is loose in extension and tight in flexion. So what would we do? If it is loose in extension, we need to either put more distal femoral augment and use a thinner polyethylene. Secondly, the same thing can be done by our offset stem. You can move the component anteriorly, or use a smaller component and increase the poly size. And these are 3 things you can do for the same algorithm. Now for the next algorithm, if it is tight in extension and it is okay in flexion. So when we think the posterior part is well balanced, and I would cheat a little bit by resecting additional distal femoral bone to the limits of 4 to 5 mm to balance the gap with the thinner poly. So number 5 I would say is okay, you don't need to do anything. For the number 6, it is loose in extension and it is okay in flexion. So just use distal femoral augment. And this is one of the most common conditions that we encounter. If it is tight in extension and loose in flexion, and many times mid-flexion instability, flexion instability that we encounter is in this condition. So what we can do? We can either cheat, as we said earlier, to resect additional distal femur and put a thicker polyethylene, or you can use a thicker posterior femoral augments or a larger size. I wouldn't go for a very large size because it will cause overstuffing of the joint space and create patellofemoral problems. And if it is okay in extension and loose in flexion, use an offset stem to move the femoral component posteriorly. And the last is, if it is loose in both sides, you can just use a thicker polyethylene. Or you can, after all this flexion algorithm has been used, many a time we find the knee is well balanced and the need for constrained components is not required. The whole purpose of this exercise and this steps is to avoid the constrained components. But even after all these stepwise approach, you feel that this has not been done, you do not hesitate to use the constrained component, either TC3 or CCK, and in case of massive femoral bone loss with loss of ligaments, even a hinged prosthesis or a tumor prosthesis. So cemented revisions has shown very good results, 83 survivalship. The chances of infection, as in all revision settings, are higher, so are the complications. And another study by Rosenberg et al. So in all summary, we have to restore the anatomy, stability, rigid fixation, pain-free function. Balancing on a revision knee is not rocket science. It is just like a primary knee arthroplasty. Just go step by step and you will be okay. Just case examples, a 65-year-old female with synovitis, synovitis, pain, intra finding a lot of metallosis, and the poly is weared out. So after removal of everything, as we said, you can see the whole removal of the components, they are still, the bone is good. And this is the final components in place, just a TC3, no hinged in anything. And this is the final results we can see. Another case example for an infection, Prostelac, and the final revision. Thank you for your patient hearing. Thank you.
Thank you, Amrit. Very good. And thank you to nearly sticking to time. I had to give you some extra seconds because we buggered up your computer thing there. Listen, we proceed to the next speaker here. Dr. Shekhar Agarwal will talk on periprosthetic fractures and total knee replacement. Dr. Agarwal, your time allocation is 15 minutes again.
Well, good morning and greetings from New Delhi. This is a charity trust hospital that I run for the last 17 years in the old city of Delhi. So I'll be talking about periprosthetic fractures around the knee following total knee replacement. If you look at the risk of periprosthetic fractures, it is certainly low for primary total knees, which is about 0.6%. And when it comes to revision, it is 3 times that, which is about 1.7%, more in patients who are above the age of 70 and more in female patients. The incidence is certainly going to increase because younger patients are undergoing knee replacements and they are living longer than ever before. So even otherwise, the incidence of periprosthetic fracture is rather low. The most common fractures that you see are in the femur, which is in the supracondylar region, and fractures around the tibia are usually associated with a malaligned or a loose component. These periprosthetic fractures are usually associated with patients who have osteoporosis, patients on steroid. They are usually patients who have rheumatoid arthritis. Then certain neurological disorders, ataxia, seizures, and Parkinsonism. Local notching, particularly if you notch both the condyles of the femur, osteolytic bone defects or malaligned components, and finally if you have a stiff total knee and you try and manipulate, you can land up having a periprosthetic fracture. How are periprosthetic fractures different? We know that these patients have osteoporosis, they have multiple comorbidities, they have deficient bone stock, presence of an implant with endosteal blood supply which is poor due to the presence of cement and implant, and periprosthetic stress riser are also present. First, I will dwell onto the periprosthetic fractures around the femur. the intraoperative fractures usually occur in the condylar region. They occur as a result of impaction of the component that you're trying to insert, or they can occur as a result of avulsion, particularly in a very stiff knee. I will mostly talk about the supracondylar fractures of the femur, which are the most common fractures that we encounter. And here I will take you through a very simplistic classification. I don't think we need to know names, but basically type 1 is a fracture which is an undisplaced fracture and your prosthesis is stable, or a prosthesis is well fixed, as you see in this example over here. The type 2 is a displaced fracture, but the prosthesis is still intact or it is not loose. And an example like this, which is you get a periprosthetic fracture soon after a total knee, and you find a fracture is displaced but your implant is stable. And then we have the type 3 where the fracture could be displaced or undisplaced, but the prosthesis is loose. As you see in a case which is after several years of total knee, and the patient gets a fracture which is usually after a loose prosthesis as well. So if we look at objectives of treatment, they are usually, as in any fracture which is intra-articular in nature, so we need anatomic reduction, we need a stable fixation, early mobilization, and try and regain pre-injury mobility. So in my mind, operative treatment is our best bet in treating these periprosthetic fractures. So if we look at type 1 fractures where the fracture was undisplaced and the implant is well fixed, the treatment could be with traction, cast, or orthosis. We have to ensure that we maintain the alignment and mobilize as union progresses. Complications, we must all know that malunion with resultant diminished function, limited motion, and early implant failure. You could land up into non-union, cast ulcers, and even DVT. And you must remember that most patients are elderly and they have osteoporotic bones. When we move to type 2, these are the most common fractures that we see in our clinical practice. Previously, we used to use percutaneous rush rods or TENS nails. You could stabilize the median and lateral columns with 3-point fixation, but these fixations were never adequate, and we had a higher risk of non-unions and even infection. The other type of fixation is in a displaced fracture, which is implanted well stable or well fixed, is a supracondylar nail, but we have to be very sure that the prosthesis is going to accommodate the nail. It has a box which will allow the nail to pass through the supracondylar region. So here's an example of a 52-year-old lady who had a supracondylar fracture. She was rheumatoid and the plate failed, and after that we used an intramedullary nail, a supracondylar nail, which was the expansile type of nail, and a 2-year follow-up on this. But she presented even after that at 6 years follow-up and presented with pain and difficulty in loading that knee. And if you see the lateral, clearly the nail is broken, the fracture is not united, I have hardly any bone over there, and then you will have to get onto a revision situation where you use an LCCK. Even the nail itself was impossible to extract, and we had to ream and thicken and widen the medullary canal or widen the nail to try and insert the stem of the prosthesis. Retrograde nailing, why is malunion a problem? These are because metaphyseal fractures with large canal. You have a fixed starting point which you cannot control. There is difficult reduction because you must reduce the fracture prior to reaming. This is the fundamental principle of intramedullary nails. And then you also have poor distal fixation because of poor bone stock that is there after these fractures. So to my mind, the usual options are DCP, LC-DCP, or the condylar plate, but locking compression plates, I think, have taken us a long way in managing these fractures. Here's an example of a type 2 fracture in a 56-year-old lady, 15 months post-surgery, implant is well fixed. She was treated with this condylar plate with an allograft that was put on the medial side. And at follow-up, this plate also bent, it gave in, and then was subsequently treated by a double plating and finally a good outcome. Locking plate fixation, they work on principles of rigid fixed angle fixation. We all know the principles on which they work. You can use them by a minimally invasive technique without actually opening the fracture. And this is a report in the Journal of Arthroplasty 2011 where they reported on 16 patients, all patients united. There were no complications. And they concluded that LCP is a good option in the management of periprosthetic femoral fractures after a knee replacement. Here's an example, type 2 fracture where the prosthesis is really well fixed and a satisfactory outcome using the locking compression plate. This one is rather simple, where you have a fracture a little higher up than usual. This is really not in the supracondylar region, and at 7 months, by treating with a LCP, you can get adequate callus formation and satisfactory outcome. This is an example of a patient of mine who at the age of 58 underwent a knee replacement, and immediate post-operatively you can see that I have notched the anterior cortex of the femur, and 10th day post-operative she returned to my clinic with a periprosthetic fracture, which is again a type 2 fracture. So I treated as usual with a locking compression plate, but over a period of follow-up, over 3 years, you can see that the fracture obviously did not unite, it was malaligned, and the fracture had collapsed. So then you have no other choice but to do a revision LCCK type of an implant. When you come to a type 3 fracture, which are the most difficult to manage, these are again, to recapitulate, fractures which are displaced or undisplaced, but the implant is loose. So in these situations, you need to do a revision knee with stabilization of the fracture, or use a distal femoral allograft reconstruction, or you can even go on to revise with tumor prosthesis or a custom made distal femoral implant. As you see in this example, this is a type 3 fracture and treated with a CCK type of prosthesis with femoral allografts that were used to bridge the bony defect. I'll quickly move on to, do I have some time? To tibial fractures, I think patellar fracture is totally different game. I will not include in this talk, but tibial fracture I will quickly include. And for this, we use the Mayo classification, type 1 to 4. Type 1 being fractures of the tibial plateau. Type 2 is fractures which are adjacent to the stem. Type 3 below the stem. And type 4 avulsion of the tibial tubercle. Again, the subtypes of all these 4 are A, when the prosthesis is well fixed, B, when the prosthesis is loose, and C, it is intraoperative fractures. So we look at the type 1A, which practically never occurs, but in type 1B, there is a medial tibial plateau with cavitary or segmental defects, and the treatment for this type 1B is a bone grafting or cement fill or metal augments, or you can even move to a custom prosthesis. I don't have an example to show you for this. A type 2A always occurs following trauma, and the treatment is rigid immobilization until the fracture heals, and all these patients regain preoperative range of movement. Type 2B occur adjacent to a loose stemmed total knee, especially with hinge designs in the presence of extensive osteolysis, and the treatment for these type 2B is extensive structural or mossealized bone grafting with a long tibial stem. Type 3 occurs which is in a post-traumatic situation or as a stress riser, usually in association with the tibial tubercle osteotomy. The treatment for 3A is conservative with a knee brace, or you can go on to an LCP fixation with bone grafting. Type 3B, you use a long stemmed tibial component, as you see over here. Type 4 is extensor mechanism disruption or avulsion of the tibial tubercle, which is usually catastrophic. Your implants are usually, or the components are well fixed. The type 4A is undisplaced. You can treat cast in extension. If they are displaced, tension band wiring with internal fixation. If you have type 4B, in which the implant is also loose, then you need to revise with extensor mechanism reconstruction. So just to take home message from this talk is that periprosthetic fractures in the situation of a total knee are very challenging. They are usually worse than you anticipate, worse than they what look on the x-rays. You should anticipate your implant is loose in spite of good looking x-rays and be prepared for revision. If you have a stable implant, you can go on for internal fixation using especially a locking compression plate, but even then your outcome must be very guarded. You must warn your patient that you may still land up into revision. However, if you have a loose implant, then certainly there is no other question but to go on to a full-scale revision. Thank you very much for your attention.
Thank you, Dr. Agarwal. Excellent, very nice examples. I have a special interest in total knee and periprosthetic fractures. Please stay back for questions. You can take a seat back, and I'll get the next speaker, Dr. Agarwal. We'll get you back for questions later on as a panel discussion. Can I go on to the next speaker, robotic surgery, Harshvardhan Hegde? Dr. Hegde? Is Dr. Hegde around? Is Dr. Hegde, is Dr. Maria around? Sanjeev, is he here? No. So could I request Dr. Sanjay Shrivastava? He's actually in the next session, but he's requested, and because we have time, I could ask him to give his talk.
Hi. Good morning, everybody. I've been asked to speak on arthrofibrosis. I'll be pertaining my presentation to arthrofibrosis following a total knee replacement. Arthrofibrosis, as we all know, it is an inflammatory rapid growth of tissue or scar tissue in the joint following an injury or surgery. And it's a really disabling condition. But whether arthrofibrosis is causing stiff knee or a stiff knee is resulting in arthrofibrosis, that is the question. And I feel otherwise. Pure fibrosis is actually of a rare occurrence. And most of the cases, because of the loss of movement, there's fibrous overgrowth and the tissues become tight, and that result in a stiff knee. A lot of factors which are responsible for this, and starting from the patient itself to surgeon to the implant. These are the range of motion normally your patient requires for moving around, and most of the cases 95 to 100 degrees of flexion is good enough for day-to-day activity. But if you see the literature, Aglietti has described it way back in 1989 that there is stiff knee, criteria for stiff knee, that is if your knee is not bending beyond 50 degrees after 4 to 6 weeks of rehabilitation, or you have a fixed flexion deformity of 20 degrees, it should be labeled as a stiff knee. But I don't think this criteria holds good today. In today's world, people have changed this definition, and now it is accepted norm as if your patient is not gaining 90 degrees of flexion by 4 to 6 weeks, that should be labeled as stiff knee. And if your patient is having persistent 15 degrees of flexion deformity, it should be labeled as stiff knee, and you should proceed to treating that patient in that line. There's persistent pain, and patient is walking with limp and abnormal gait patterns. Patient has to exert more for the same amount of movement what he requires for daily activities. And if there's a flexion deformity, it even complicates issues further. And because once your knee is flexed, the patellofemoral joint has different forces acting on them. A lot of force has to be exerted by the patient to walk around and do normal activities, and that force is transmitted along the joint, and patient tends to exhaust early. One factor which has been universally accepted in most of the series as one important factor for post-operative range of movement, and that is the pre-operative range of motion. The more you have, better you have post-operative range of motion in the post-operative phase. Other factors which are responsible are maybe a single factor or maybe multifactorial. We'll be discussing these things. As far as patient is concerned, we all understand that if patient is short and obese, definitely he or she is going to have a lesser range of motion. But if patient is not doing adequate post-operative physiotherapy because of multitudes of reasons, or there's inadequate analgesia, patient is in persistent pain, definitely patient will not be able to perform the physiotherapy as we required, and patient will have a stiff knee. Issues related to implant and surgical procedure itself, as if there is an osteophyte on the back of the femoral condyle, or there's a loose cement there, or if we have not done an adequate posterior capsular release in cases of flexion deformity, definitely we are going to land up in a flexion contraction. Likewise, if extension gap is too tight and flexion gap is loose, there's a mismatch, and we have not resected distal femur good enough, so it will again make our extension gap tight, and patient will have a flexion deformity. The reverse of it is true if your flexion gap is less and extension gap is more. You have resected more femur, or you have overstuffed your joint with a larger size component, or your femur is mal rotated. Femur is critical in placement when we talk about the flexion extension gap. It should be placed ideally along the center of the mechanical axis. If it is too anterior, you are actually overstuffing the anterior structures, and your quadricep mechanism becomes tight and patient will not have a normal flexion. Likewise, if your femur is too much posterior, you are actually increasing the posterior offset, and this is resulting in decreased flexion space and again leading to the flexion deformity. If your femur is mal-rotated, your quadricep mechanism is not working properly, your patella tends to dislocate on the lateral side, and that is producing pain and patient is not gaining the flexion range of movement. If your patella is overstuffed, again the quadricep mechanism is tight and you will not be able to regain the good movement. Few reasons for tibial reasons for the loss of flexion. If your anterior slope is reversed, a patient will not have good flexion. And if you place your spacer too tight so that the collateral ligaments, they are too tense and patient is having pain related to that, that will not allow the patient to do proper physio, and then patient will not be gaining the movement as desired. In case of CR knee, if your PCL is tight, that will result in, as we see on table, the anterior lift off, and that is going to give you a bad postoperative range of motion. If your joint line is elevated beyond a certain limit, and if you have a patella baja, then again flexion range is decreased. Other reasons, if there is a reason for secondary pain from any source, that will also result in loss of motion. Other causes related to surgical procedure itself, most common is a low-grade infection and a heterotrophic ossification, which can lead to loss of motion in the body. It's very important to understand these factors and to identify so that we can understand what is causing it, and then we can treat it. Because if you are not able to identify the reason, you will not be able to treat it in a proper way. Apart from general examination, it is very important to undertake the examination of the spine and hip. Many of the time pain is originating from some other source and patient is not able to do rehabilitation because of that, and we are focusing on the knee itself. Radiological analysis is important to see whether our components, they are in proper position and proper alignment, whether we need to change them or we are going to accept them. CT scan is imperative in judging the role of femoral rotation, because it's very difficult to judge femoral rotation beforehand. CT scan give you a good idea about that, whether femur is wrong and whether we are going to revise it or not. It is imperative to rule out infection, because any procedure you do, if there's an infection, it is going to fail. Infection, there are a lot of things are being advocated, and bone scanning, especially a gallium labeled leukocyte scan is being done. But till date, the joint fluid aspiration remains the gold standard. If you aspirate the joint fluid and total cell count in the joint fluid tells you about a good idea about whether it is infected situation or not. Cultures are going to be negative, so it is of no use. Coming to the treatment, what we can do for these stiff joints, these are the variety of things available, and when we are going to treat it, when our patient is not gaining movement up to the 90 degrees by the time of 6 weeks, that is the time when we are going to act. There is no progression of range of motion, or initially patient has gained movement and then it has lost it, or there is a very hard endpoint to the flexion. These are the indication when we progress to manipulation, and manipulation should be done as early as possible, not delaying it too far. You should never go beyond 3 months, because the literature has shown that if you go beyond 3 months, the chances of complication related to manipulations are very high and you will not gain anything out of that. If you apply too much of force, then extension mechanism rupture it can happen. You can produce a supracondylar fracture. Hemarthrosis is parcel of manipulation. You have to manage it, and of course associated with the risks associated with anesthesia are there. It can be done as a daycare procedure, a general anesthesia with a good relaxation, and immediate utilization of CPM as well as the ice pack is imperative to reduce swelling and to reduce the pain of the patient. Continuous epidural can be used if your patient is hospitalized and they can remain in house for few days. It's good. You can control pain on epidural, and patient can be mobilized on CPM for few days. If your manipulation fails or patient is beyond 3 months, it's not advisable to go for manipulation, and then you can go for an arthroscopic arthrolysis and then manipulation. It has been advocated it is most useful if there is a tight PCL in the CR knee. But if you talk about regular arthroscopic debridement, it's really very difficult to do it. It's a hard, tough tissue to remove, and you'll not be able to create a normal joint function with arthroscopic arthrolysis alone. And people have not been able to give very good result with the arthroscopic arthrolysis. Then comes your last option, that is the open arthrolysis procedure. And joint is very stiff, scarred, and there are a lot of adhesions around. The exposure is difficult, and you have to really ease out with the exposure. Usually we use the same incision which has been used, and but the thing is there's no role of minimal invasive surgery. You have to go for a longer incision and a liberal exposure. You have to re-establish the medial and lateral gutter. Pinning the tubercle is a good idea. It can prevent an accidental avulsion of the quadriceps tendon. And as soon as you are able to expose it, you remove the insert so that the joint is decompressed and you can mobilize it in an easier way. Patella avulsion is not advisable and lateral release is must. As already Dr. Goel has mentioned, these are the additional procedures which can be done to ease out the extensor mechanism stress. Most of the people, they are not using now VY-plasty. We get away with the quadriceps snips most of the time, and if a total component revision is required with a stemmed implant, you might go for the tubercular osteotomy. One simpler solution can be done during the surgery if your joint is well aligned and well fixed, and you just have a tight space in both in the flexion and extension. And there is a minimal mismatch which you can get away with just downsizing the component and going one size under, and you are relaxing the ligament, and you might get away with the problem. But I think it's a very small part of the situation, and most of the time you will not find a situation in which you can handle this by this only. And then you need either an isolated femoral component revision or a total revision. Femoral component revision, as we have seen in the previous talk, gives you full control of the flexion and extension gap. You can very well control it. But if you are not comfortable with the implant which has been used, you can go ahead and do a full revision, including the tibia. And literature has shown the full revision has the best outcome and least complication rates when you talk about the stiff knee. And rest arthroscopic, as I said earlier, very high failure rate, and it's not working very well. To summarize, most of it's a problem condition which we come across regularly, and it is one of the topmost reason for patients' dissatisfaction as well as our dissatisfaction for the outcome of the total knee replacement. But most of the conditions, they are beyond surgeon's control, and I feel prevention is the best way to identify correct patient and do a meticulous planning and meticulous surgery, and good physio must lead to a good result. Thank you very much for your patience hearing.
Thank you very much, Dr. Shrivastava. We are running actually ahead of time, very unusual for, I'd like to again ask if Dr. Hegde is here, because his time was 11 a.m. for robotic surgery. Is Dr. Harshvardhan Hegde around? No? And Dr. Maria is also not here. Okay, what I'll do is I'll open this for discussion. I would say that I'll allow questions for anybody who wants to ask questions to the panel, please. Yes, you would. Can somebody help with the microphones and all this stuff? In the meantime, okay, you could ask the question first.
Yeah, I'm Dr. Khare. The question to Sanjay. There is also one important role of the arthrophysis is the psychosomatic. Some of the patients are very fussy, they don't do the exercises. You have seen they have done everything right. How you deal these patients? And question number 2, how frequently you can do the manipulation under the anesthesia if his patient is not recovering?
As I've shown in one of the slides, that the patient factors, poor tolerance of the pain is one reason for not getting a flexion properly. That is why it is very, very important to identify these patients before surgery and counsel them and rehabilitate them before the surgery. Because once the surgery is done, and if your patient is not cooperating, it's really a hell of a job to gain movement. Secondly, in initial postoperative phase, what we do, we are using continuous epidural for a little longer period, maybe up to 5 days. Because once the patient gains initial range of motion, they have confidence on the knee and they know they can manage it well in the postoperative phase. That is why I always prefer to counsel these patients, to send these patients to the physio before the surgery so that they understand what has to be done and what it will be. And it won't be a 100% pain-free surgery. That should be sticking to their mind. Regarding manipulation, I must say it's very, very infrequent in my practice. Maybe 0.5% you can say they require it. And the reason being, initially patient is not gaining movement and you tell them to go under manipulation or any other arthrolysis procedure, they tend to defer it. They say, I want to try some more time. And gradually after some time, actually you lose patient. So patient don't come to you for your own cases. But definitely, I have revised a few of the cases of my colleagues, but they were late and open arthrolysis has to be done rather than manipulation. So manipulation, in my practice, I have done very infrequent. Literature says no. Yeah.
Yes, Dr. Khare, thank you very much for asking that question. For Dr. Srivastav, the thing is that, have you ever used tranexamic acid? Has anybody used this? Because that reduces a lot of bleeding, and you know we use that often, and you can get rid of. Yes.
I use it routinely.
Okay, very good.
15-20 minutes before I open tourniquet, if I'm using tourniquet.
Absolutely.
Otherwise, 10 minutes or 15 minutes before my incision, I give it.
Absolutely. So half an hour before 1 gram, we get 15 milligrams per kg body weight. That's true. Yes, Dr. Professor Rastogi, yes, please. Would you like to ask anything?
Yeah, question to Sanjay. Would you change your protocol for different indications of total knee replacement? Like, for example, patient with rheumatoid knee and a stiff knee, and patient with osteoarthrosis and a stiff knee.
Oh, you really put the bar very high there. Okay. Sanjay, it's up to you.
Definitely your protocol or your planning changes as you see these patients. If I talk about rheumatoid knee, most of the rheumatoid patients, they are very tolerant and they have been tolerating pain for a very long time. And as soon as their pain goes, they are very comfortable moving their joints. So I'm really not worried about them. And they have a very low expectation. When you talk about an stiff knee, you really have to put their expectation down, because whatever you do, you cannot guarantee that they will have a fully functional 100% normal range of motion. Or you really have to counsel them what you are going to achieve and what you are not going to achieve. When you talk about osteoarthritic knee, you really have to assess the patient, because most of the patients, they have a very high expectation. They want to run, they want to do everything what they used to do 20 years back. So that is how we differentiate, and I think it's very, very based on the patient itself rather than a diagnosis of the patient. Definitely. Many of these studies, they have done it, and we also do it. Ketorolac along with the bupivacaine, morphine, all these type. And especially injecting the posterior capsule and the posterior lateral aspect, it does help in reducing the analgesic dose in the posterior. Yes.
Yes, that's very good. Thank you. We move on to Dr. Rastogi or Professor Rastogi. Anybody has questions for Professor Rastogi here? Professor Rastogi, I want to ask you as a chair that what would the do you routinely do standing up and 3 feet films in your institution?
Standing up X-rays?
Yes.
Yes, I do.
Oh, you routinely do that. And
a CT scanogram is a must, and a standing APB is also missed. You can't get a standing lateral.
Okay.
But, you need to get a standing APB.
Okay.
And there's a huge amount of difference. You see a patient with a standard on the table AP X-ray and standing X-ray, and you can, and the difference is amazing.
Very good. Excellent. The other thing on, sorry.
You do a standing X-ray or you do a single leg stance? Single leg stance. That's important.
I'm sorry if I just said.
All right. Okay. Yes.
I do go for scanograms. The reason is that it's easier to get to know the mechanical and the anatomical axis, because in this CT scanogram, if you've got a good technician, he will be able to plot out the axis for you. So you don't have to do that all that much, and it also gives you a very good idea of how much deformity the patient has.
Very good. Just on your question to Dr. Shrivastava, what he asked about making it the primary knee complex, we always call it a sort of complex primary rather than a primary knee, and we always keep the kitchen sink ready so that you might convert it after taking off a lot of tissues. You might suddenly find that the primary knee will not be stable. You might just come out putting the implant, but it's going to fail. A knee is, you all senior knee surgeons, you understand how unforgiving is knee for a few millimeters this way, that way in alignment. Take it on to ICO's work on it. He's a number of publications on alignment. So I would always counsel my patients that in case I cannot get it a full sort of a stable knee, I might just convert it into a constrained or go for a implant which would be sort of LCCK or whatever you want to use in your institution. No further question for Dr. Rastogi. Can I go on to Dr. Agarwal, whom I've known from previously? Very nice talk, Dr. Agarwal. It's my area of choice also, totally. Anybody has questions for periprosthetic fractures for Dr. Agarwal? Any questions for Dr. Agarwal? Yes, Fuyan. Fuyan is from Hong Kong, or Charles as we call him. Yes,
My
Charles.
name is Charles from Hong Kong. I represent the Hong Kong Orthopedic Association to come to join the meeting. Thank you for your talk. I love it very much. I would like to know whether you consider to use bisphosphonate or other new biological agents which can improve the bone growth for your periprosthetic fracture, especially those cases with rheumatoid arthritis, which we know that the bone healing is a big problem. Because we know that locking plate is good, but still the bone growth biology is bad for this case. Thank you.
I think as a policy in my unit, everybody gets an injection of vitamin D0. I like it all at the time of admission because we did do a study and we saw all the population that was coming for knee replacement. 90% of women were vitamin D deficient. Okay, so they get that shot at the time of admission. And after 6 weeks of surgery, everybody goes on to a bisphosphonate with a calcium supplement for a period of 2 years. Beyond that, I do not recommend because I don't know whether they will come back to me for follow-up or not. I'm safe to give it for 2 years, no more than that. But having said that, I haven't seen the incidence of fractures going really up. There would be a time for a year I would not get any, and then suddenly within a week I will get 3.
Yeah.
So it happens like with any other surgery, like most of the surgeries.
Everywhere.
True. But the incidence is really not all that much. I thought I'll see far more fractures than I'm seeing actually. And that goes true for the hip also.
That's true. Yes, Dr. Khare, please.
Dr. Shekhar Agarwal, I feel that those patients who are bedridden, like rheumatoid, etc., those who are not walking too much, I think we should have extra precaution while we are doing the total knee replacement because they are more prone for this sort of fractures, and it's very important to go for a BMD and other bone scan to see the condition of the bone.
I've not been really impressed with getting their bone densitometry test done or DEXA scans because 100 out of 100 they are less than minus 2.5. 100 out of 100. Even mine is less than 2.5. Doesn't mean that. So I don't know how much is the authenticity of that test. Some people claim that that is as accurate as measuring a blood pressure.
Yeah.
But I don't believe that. But what the problem that I've seen in patients who have not been mobile and you do a knee replacement, they come with fractured neck femur. Within 6 weeks or 2 months, they start walking, family is worried, you think something gone wrong with the knee, you x-ray the hip, and you find a fractured neck femur. So that has happened to me on a few occasions.
Okay, yeah.
Yes, so that is why I give them, they are sort of captive population at that time. So some people even go to the extent of giving a zoledronic acid prior to discharge, so that for a year they are covered with bisphosphonate.
Yeah.
I don't do it because it doesn't come into the package deal that I offer my patients, so I don't use bisphosphonate at that time. But sometimes that can also add to a lot of pain. So you need a bit of steroid cover or some analgesia. But I think it's a good idea at the time of discharge, give them an injection of zoledronic acid and then they are all right for a year.
Okay.
Otherwise, taking a pill every month or every week may not be a practical thing. And the elderly patients may not want to spend money, or the children may not want to spend money on them. So
Right.
before discharge. So 5th day or 4th day or 6th day, whenever you're discharging your patient, give them an intravenous bolus of zoledronic acid, supplemented with calcium on a daily basis, and that way that osteoporotic problem is taken care of.
It's very interesting because I am so used to doing the Asian population in England and Southern Ireland that we always find them to be the Asian, the bone Asian, the quality sometimes, because living abroad for a long time with low amount of sunlight, they get, and then we have certain religious issues in which I find these women especially, the bone quality is so poor. Doing a primary TKR, you have to be so careful because you can have the subsidence of the tibial plate. So it's fantastic there. Dr. Agarwal, before you take your seat, I would like to ask you, do you have any, is polyaxial plates now available in India? That's where you use...
Polyaxial plates are available.
Yeah.
I think Zimmer makes them.
Okay.
But the trouble is, no matter what you do, the bone underneath the femoral prosthesis, the condyle, is unpredictable. The implant is so big that you cannot see it on the X-ray, even on a CT scan. And the bone invariably is like a hollow eggshell.
That's very good.
I think you need to do some kind of packing, grafting, some kind of that paste that comes with from Synthes that you can inject to increase the quality of bone to put the screws in. I think that collapses even before the fracture can unite.
We have a huge problem of aging. In Europe, the population aging big time. People live to the 90s and they come back with these periprosthetic fractures. I think it's a very complex thing. Yes.
It's more useful in the hip.
That's right, yeah. Prevents you. Indeed. That's true. That's so true. Yes, anybody else for Dr.